Hello all, this is Dr. Bernard Morrey. I'm the Chief Medical Officer for Tenex, and first of all, I want to express our appreciation for you giving up your evening to hear of some of the advances that have been made with this technology. We're very pleased to introduce our presenter, Dr. Rahul Desai, who will present on primarily focusing on calcific bone removal around the shoulder, but also in other areas. Dr. Desai is a musculoskeletal radiologist. He's an expert in interventional radiology and is involved in interventional joint and spine medicine. He's a founder of the practice, which is called RestorePDX. He's from around Portland, Beaverton, Oregon. He's also the president-elect and current vice president of Interventional Orthopedic Foundation. He's got a great depth and breadth of experience with Tenex, and we're very excited to have him share his insights and experience. But a few housekeeping concepts or ideas before we get started. There's a lot of participants, and we'll be muting all the phone lines during the webinar. So if you have any questions, and we anticipate them, please, during the presentation, jot them down. They will appear, and we will try to aggregate and then answer all the questions that we possibly can. And if for some reason or other we run out of time, please contact Tenex Health with your questions, and we'll try to answer any that may not have been answered on the webinar. So with that, I'll turn it over to Dr. Desai. Rahul, thank you so much for your time and for sharing your expertise.
Thanks, Dr. Morrey, and want to thank the Tenex team for helping put this together. And again, also thanks everybody for coming in and spending your evening. Hopefully, I can impart some of my experience, kind of like my show and tell, about rotator cuff, calcific tendinitis, and Tenex percutaneous tenotomy. Have a breadth of experience in other areas as well. So, if there are questions at the end, we've treated, from shoulder, rotator cuff to, the elbow, medial lateral epicondyle, moving down to the hip, the, gluteal insertional tendons, and the knee, quad, some really cool quadriceps tendinopathy, patellar tendinopathy cases, and down in the foot and ankle, Achilles and plantar fasciitis, and even fibromatosis. So Tenex has been a boon to our practice. I have no disclosures to make. I speak for Tenex right now just as an advocate of the technology. Also, I am, like Dr. Morrey kindly introduced me, involved in the Interventional Orthopedic Foundation. And it's really a hub. It's a nonprofit, one of the largest nonprofits out there in this space. And I would urge you all to take a look at the website. Membership is crucial. We are non-biased. It's kind of a non-denominational regenerative medicine organization. Dr. Jared Malanga, who used to be former president of AAPM&R, is the current president, and I'm vice president, president-elect for next year. We want to grow the organization, and the foundational pieces are just to get this type of medicine out there, and we call it interventional orthopedics because it's not just regenerative medicine. It's tools like, or when we consider regenerative medicine just as PRP and biologics, it's not just that. It's some other interventional orthopedics, like a percutaneous carpal tunnel release and also percutaneous tenotomy. And what we're doing here with demonstrating Tenex tonight, there are all of these institutions receive scholarships for their residents and fellows to come and learn. And it's a grassroots program. I hope everybody can get involved. I want to also thank my family for letting me stay at work late tonight, and my wife for taking care of all these kids at home. And so thank you. Hopefully they can watch later. So we're going to talk about rotator cuff, and the problem is the most common source of shoulder pain. 30% of the adult population. It's a spectrum of disease ranging from a tendinopathy, tendinosis. What we're going to focus on is kind of calcific tendinitis, partial thickness tears. Full thickness tears is getting out of our control here, and then retracted full thickness tears, and then atrophied tears. So the risk factors, some things unfortunately we can't control. Age is always moving, right? Time is something that we can't stop. But there are things, and I would be remiss not to talk to you about those, that we can change. And so when we get into the regenerative medicine realm and those that are less experienced, I think something that's really important to look at is the overall picture, right? We want to see the forest from the trees, and we got to talk to these patients about other things, whether adiposity, overweight, metabolic disorders, and then also kind of the more mechanical things, muscle imbalances, decreased flexibility, repetitive arm motion. I like this chart. We have the reference below. It kind of breaks down the difference between extrinsic or mechanical issues that will cause rotator cuff pathology, but also the intrinsic mechanisms. And part of this is that metabolic syndrome. And so we focus on, in our practice, when we're trying to help people heal, we want to make sure that we attend to those other things as well, that we can make, I always tell the patients I'm the guy that puts the fires out, but we need to take care of the entire system. So we have help with our other practitioners. So part of regenerative medicine and part of when you use Tenex is really stratification of your patients. And so we're going to, we have grading of tendinosis from a healthy tendon to a grade 1, 2, 3, and 4, and that's a progressive pathway. And so where we see the regenerative medicine and Tenex in particular, the percutaneous tenotomy, helping is from anywhere from that grade 1 to an early grade 4, where there's not large defects. And especially if you start to get into, say, like an atrophic tendinopathy where there's not much tissue, then you may want to reconsider using the Tenex device, because it will cause some trauma to those few strands that are remaining, and then we may want a more regenerative approach to try to build some tissue. If you have a more prolific tendinopathy where there's a lot of hypertrophy, then Tenex is beautiful. So one of the analogies I'd like to use for my patients is to talk to them about the normal tendon. So you go to Home Depot and you buy a brand new rope. That's like your new healthy, your young healthy tendon. The tight twine, those are the type 1 collagen fibers. And unfortunately, as we age or if you have injuries, it's not a clean cut. That's not what the tear looks like. The tear is a breakdown of those fibers, and you get this fuzzy rope, and that's what that tendinopathic tendon looks like. So what are we trying to do is we're trying to take that tendinopathic tendon and reverse engineer and try to get that brand new rope appearance. And for those that are not really involved or early in their experience in regenerative medicine, there is a little bit of a leap of faith, and I hope that I can describe that and show that to you tonight, that this actually can occur. And then on top of this, kind of the analogy expanded is that if you have calcium in there, I like food and like to eat too much, but having that M&M and the chocolate in there, right? We're trying to get out the chocolate so that the tendon can heal. The traditional mechanisms with which we've treated tendinopathies include physiotherapy, medications, NSAIDs, narcotics, pain relievers, sometimes alternative medicine therapies, and then unfortunately steroid injections, and then surgery. And I really think that what we've seen and I've used all of these over the past 10, 12 years that I've been in practice out of fellowship, and nothing has improved the outcome for our patients compared to what we're doing now with the interventional orthopedics. We've gotten better and better. And part of this expansive tool set is the Tenex procedure and the percutaneous tenotomy, and I've really been very pleased with it. And so that sits in this interventional orthopedic realm, and then with the regenerative medicine, it's kind of synergistic. And we're seeing more and more of this, and I think that it includes surgery. So I have partners that are surgeons. I work in a surgery center, and it's an inclusive process. I think there are different things that we stratify patients in, and not one size fits all. And the more tools that you have in your tool set, the better outcomes you're going to have for your patients. The Tenex debridement, what I liken it to is trying to do trying to rebuild a house. And if you try to rebuild a house on the house, with the house still standing on the left, it's really, really difficult, right? And so that's what we had been relegated to. We had supratendinopathic tissue in a rotator cuff, and we would treat it with PRP or treat it with regenerative medicine therapies, and it would heal, but it would take a long time. There's fibroblast and macrophage activation, but your cells, like little Pac-Man and Pac-Woman, had to clean up all this mess, and it took a long time. So sometimes you're doing 2, 3, 4 treatments, and sometimes it just wouldn't work. You have fibrotic tissue, and you just don't get any vascularity to the area. It would be a lot easier to heal if we started with this right-sided picture, and so that's kind of the Tenex debridement. This is a video that I'm going to show of kind of the old school calcium lavage aspiration, so 18-gauge needle into a large calcium deposit, and you can see puffs of cloudiness coming into the syringe, and that's the calcium that I'm washing out. So this is a very manual technique, but it was pretty darn effective. We started to use less and less steroid with this, but you can see how cloudy the syringe is getting, and it started out very clear. This is an example of this type of technique, and here's a large calcium deposit. This is a non-shadowing, so you can see all the way through it. This is in the rotator cuff, and you can see the needle that's going to enter, and this is placed directly into here. The next video, so I'm kind of futzing around here, so should have probably accessed that a little bit more easily. But the next video shows that this needle in the calcium, and you can see that I put suction on the syringe, and through here you're getting this toothpaste-like material, and it can be very effective in debulking the calcium. And you can see here, this is after the needle is in there, and we're washing. I'm trying to wash out as much of the chocolate out of the M&M as possible. Right? And so this is within the rotator cuff tendon. You see deltoid musculature here. So that's an intratendinous lesion. This was one of the problems I encountered, was my thumb hurt because it was a manual technique. And so, sometimes, they would set up, my schedulers would put 2, 3, 4 in a row, and I would come out of there and just dreading my CMC arthritis. And over several years ago, we were luckily introduced to Tenex, which automated this process and did a lot better job. The other part of this that the Tenex does is that it takes away the penumbra of that dead and diseased tissue. So not only, when we get into the calcium deposit, such as this, the rim of the calcium is still left, and you can see here that as we're washing, you have this penumbra of tissue. Now the adjacent tissue is probably not super healthy either, and that's something that I feel like the Tenex does a really good job with. This is the setup that we have, so definitely like ergonomics is really important. Have needle pointing towards the screen. We have a nice setup, sterile field, and we're able to do that. The Tenex makes a particular specific noise. I'm going to turn it on here. Hopefully you guys can hear that, but this is after I'm stepping on the foot pedal. It kind of sounds like a dentist drill, right? And so that's what we're going to do. And so there I'm in a large calcium deposit. This is a zoom up on the screen of the ultrasound, and you can see here, those are the vibrational shadows here, and here's the needle device going through that tendon. And so that's an intratendinous. That whole thing right there is the calcium deposit. It's shadowing. You can't see the humeral head. It's within the tendon, and there's some fluid within the bursa. This is the MR imaging of this calcium deposit. So a pretty huge calcium deposit right at the supraspinatus insertion. And so you can see the needle passing through here. And as this passes through over time, this calcium, which was dense and mineralized and shadowing, is going to get less so, and you're going to start to see through it. You'll start to see within it, and then you're going to start to see the outline of the humerus. And that's the aspirate that we obtained from that patient, which is going to have a combination of the calcium, probably some dead and necrotic, fibrotic tendon tissue, and then here a little bit of blood. And bleeding in that tissue is not a terrible thing. This is a video. Let me mute this here. This is just a video of the before and after. So this is an MRI. I'm going to scroll through this same patient. And as we move through, you can see that there's some tendon disease, some tenosynovitis. And then as we move back, you're going to see that the large calcium deposit, there's some intrasubstance degeneration. And the calcium is intratendinous. So it's extending into the bursa, but most of it is within the tendon. Post-treatment with the Tenex, you can see this is the after MRI. Still a bit of tenosynovitis, but kind of pay attention to the tendon. It's starting to look really good, and the calcium is gone. This is several weeks later. Patient is doing tremendously well, and the calcium's gone. The tendon has a little bit of intrasubstance signal still, but over time, with proper rehab, a tincture of time, and sometimes synergistic therapy, we're going to see that improves. The synergistic therapy, what I really like to do, and we're working on an internal study of patients, is to do the Tenex debridement followed by regenerative medicine therapy, right? So doing the demo and then having the remodel turbocharged. And so the concept is that the Tenex is going to deliver that ultrasonic energy at the microtip, and we'll talk a little bit about that, cut the dead and diseased tissue, and in this case the calcium, while sparing the healthy tissue. And so this is what it's doing. It's going to turbocharge the healing, right? So you have this house that's really decrepit. We need to get rid of it. Tenex debridement, we're starting with a fresh field. And there's a chance that goes to healing by itself. But using the synergistic therapies, I feel like we have a better chance of getting this, beautiful new home and the remodel and that new tendon. This was a case, again, we're going to talk about mostly shoulder, but I think this is a really nice depiction of what the synergistic therapy can do. Gentleman came to see us, had been a pretty active, healthy gentleman, was even a marathon runner, had 18 months ago was running and started to have severe pain, and ran through the end of the marathon, but over the past 18 months started to get worse and worse and worse. He saw me 18 months post the beginning of this pain, and he came in last 3 months riding in a wheelchair. The worst Achilles tendinopathy that I'd seen. It was hard and fibrotic. The skin was indurated. There's a lot of kind of myxoid fibrotic tissue. This was the ultrasound appearance of the tissue. We did a Tenex procedure. I made it, to debride it. So we did a combination Tenex and stem cell therapy. We made 5 separate incisions along the length of the tendon, and then debrided it. It was kind of like a big, sausage, and we're just going to go, up and down and top to bottom and clean out all of this dead and diseased tissue. We had 20 minutes of cutting time, and then we had harvested stem cells, bone marrow, fat, PRP, and then injected that into it. He called me 6 weeks afterwards, completely pain-free. He called me 3 months afterwards and wanted to run again. And he lived across, he was from New York City. We asked him he lived across the street from HSS, where this original MRI was done. So we told him, go back and send me an image. And when he sent it back, we looked at it, and I thought we had the wrong patient. I was absolutely astounded at what happened in 3 months. And this is that after picture. And you can see this horrible tendinopathic tendon, and one that is, while a little bit thickened, completely void of signal, and looks like a very healthy and strong tendon, and the patient's pain-free. So I really believe I haven't seen this with either therapy by itself. So I think there's some powerful synergy that's occurring. These are the axials and another slice through that tendon. So what's the Tenex actually doing? Right? And so it's removing the degenerative tissue and lessening the impact of the stage of the disease. And so at the microtip, there's a lot going on. So this is vibrating back and forth at 26 megahertz. It's preferentially breaking down dead, diseased, fibrotic tendon. And through this outer cannula, you're getting an irrigation, and then through the inner cannula, you're getting an aspiration. So not only are you breaking down the calcium, you're breaking down dead and diseased tissue, but you're removing it. We have more access to different types of tips. So the TXBone tip is a little bit shorter, right? So the length is about 2.5 centimeters. And the TX2 material is a little bit different with stainless steel. It seems a little bit more robust, 4.3 centimeters. And that's allowed access to larger patients, to deeper structures, especially when you're getting into like the gluteal tendons. I forgot to mention that we've done some hamstring origin tendinopathies with some good success. And this, depending on the patient's body habitus, obviously they have to be, for those areas, they have to be relatively slim to access that. But this TX2 needle is going to provide that. Now the TX Plus or TXBone is out, and this is even a more robust needle, and that's going to be able to debride bone. I have a demo which I have not been able to use, but I've used this at a IOF course this February, and it was pretty amazing how well it cut through bone. So that's something that those indications are there. We see, enthesopathic heterotopic ossification, and I'm excited to get to use this. But here's a guide so you guys can go back and take a look at this. So in the interventional orthopedic regenerative therapy model, I think the important things that we need to look at so we are all successful and have happy patients and really allow this medicine to progress is the proper indication. I think stratification is super important, and we're going to, as time goes and studies come out, that's something that we're going to get better and better at. I am completely biased and think that diagnosis is paramount, obviously using ultrasound, MRI, CT, X-rays, whatever we need to, physical examination, and we're going to have to differentiate those things from partial tendinosis, partial thickness tears, full thickness tears. Even small full thickness tears, is the rotator cable intact, and can it work as a scaffold? And then full thickness tears with retraction obviously may not be, we need to send that to the surgeon. So we're really focusing on these, grade 2, even grade 1 to early grade 4. And I think we can augment, and I think there's a really nice place for regenerative medicine. Is it going to replace surgery? No. But is it going to work as a wonderful bridge between what we've traditionally done and what I think we should probably stay away from a lot of times, steroid injections? Yes. And so for those that haven't used this a lot and have not seen, so I've been doing regenerative medicine for about 10 years, got lucky, started in 2008, and we started to treat patients. I really didn't believe in the medicine, but I thought, hey, I'm good at diagnosing, we're good at putting a needle into a spot. We used this medicine, and I was shocked patients came back, they were feeling better, and I really didn't believe them. So I said, okay, let's get back on the MRI scanner. I have a partial thickness tear. Jump back on there and let's see what's happening with it. And lo and behold, it was healed. And we saw this over and over, and it took about 20, 30 patients for me to truly believe. It's been 10 years and about 4,000 patients later. And so the kind of that leap of faith, and hopefully it's not a leap of faith, that it becomes proven, it's all magic before it's science. And so I think that we're showing that this is actually, working really well and going from these like partial thickness tears or tendinopathy to new tendon. And so what we can treat well with the Tenex is tendinosis, this hypertrophic tendinopathy. You can see increased signal in the MRI, and then hypoechogenicity and increased thickness on the ultrasound. These partial thickness tears where there's maybe a penumbra of tendinopathic tissue. You can see these little enthesopathic bony changes there, a good candidate. Obviously, calcific tendinitis, great candidate. Debulk that tissue, allow that tendon to heal, right? And full thickness tears, not so much, right? I mean, if it's non-retracted, less than 8 millimeters, maybe we can talk about a stem cell with fat and kind of a scaffolding. But again, what's the status of the rotator cable? And so obviously, I don't think this is the role for tonight's discussion. This is a representative case, imaging 57-year-old female. When you see this type of calcium, which is very different than what we saw before on the video, where it was echogenic and you could see through it, this is very dense and hard mineralized calcium. Right? And so you can see here, it's densely shadowing. We treated this patient, debrided it, and you can see here, now it's non-shadowing. We got a lot of that calcium to go away, but there was still quite a bit left. And so this was post-Tenex, and you can see here that this is something that we need to still treat. They were feeling better, but not fully resolved. We did a regenerative medicine therapy into that. So that's what it looked like before, right? So shadowing. Now, much less dense, much less mineralized, but this is still not healthy tendon. You can see that we're seeing the interface of bone here, and we have lost that initially. So we did a regenerative medicine therapy. Several weeks later, we're at 8 weeks, and you can see very little calcium remaining versus still slightly thickened. Not perfect, but heading in that direction where we're getting this new native type tendon to come into play. Now this is out even a few weeks later, and you can see that this looks near perfect and normal. And so that's the progression of the pathology and pathway towards healing. Now, again, adjunctively, physical therapy is very important. I'm a big believer in eccentric loading, getting blood flow to the area and allowing for healing. My analogy to the patients is, when you work out, you build muscle. You put it through stress, the body responds and builds it stronger, and the same thing happens in tendons. It just takes a little bit longer, but that's what we're seeing. So we're seeing at 7 months and 11 months, virtual complete healing. This is another case, 59-year-old male, where this is pretty atrophic. I probably wouldn't use Tenex in this case, right? You got a small partial thickness tear, the tendon's atrophic. I would be afraid of, not from the Tenex itself, because the Tenex is very safe as far as breaking down healthy tissue, but simply from the needle and the trauma to the area. We can see here that we're starting to allow that tendon to heal and build. And I think that's where the regenerative therapy comes in. This was a combination therapy, a separate patient with a small full thickness non-retracted tear, part of the rotator cable. Something that if anybody's interested in, they can ask me. I have some interesting literature on that. But it's holding the tendon, the supraspinatus intact. We filled this in. I call this the gamush phase. So this is a couple months later, patient's feeling a lot better, but it doesn't look great, right? But there's something happening, something filling in here, and there's this disorganized tissue. When we use those eccentrics for a patient that was actually doing a lot better here, when we use the physical therapy, the eccentrics, the loading, this is a year later where we have neotendon. Does it look perfect? No. Is the patient pain-free? Yes. We have neotendon formation? Yeah. And the patient's doing really well. So that's that progression of healing. This was a patient that we had treated, and this was before I had used Tenex. This would have been an ideal patient for Tenex percutaneous tenotomy. Multi-fragmented calcific tendinitis, bursitis, thickened tendon, and then just kind of, some holes. It was that frayed rope. We did the therapy. It took me 2 or 3 rounds of regenerative medicine therapy, but we were actually able to get it to go from that frayed degenerative rope to basically a native-looking tendon. This was a professional drummer that did really well. And so that's kind of that analogy reiterated. This is my, kind of bringing things together. I have a 3-legged stool for successful regenerative medicine. So, and I really consider Tenex a regenerative therapy. It's in the interventional orthopedic realm, but what are we trying to do? We're affecting tissue, taking out the degenerative, fibrotic, scarred, broken down tendinopathic tissue, and allowing the body to heal and replace it with native tissue, and taking away the dysfunction and the symptoms that have been hindering the patient's activity. And so what are the 3 main legs of the stool? Are precision diagnosis, so from history, physical examination, diagnostic imaging, and sometimes these diagnostic injections. We do a lot of injections with anesthetic, with low-dose prolotherapies to make sure, especially when we're working with spine and hip, to make sure we're in the right areas. Precision biologics, I think we sometimes focus a little bit too much on this, but I think it's important. Obviously, it's going to be a progressive industry as we look at all these different possibilities that are out there, and it's super exciting. But again, if you don't have all 3 of these legs, things are going to fall down. And then precision delivery, right? I'm a little bit biased, but we definitely need image guidance, whether it be ultrasound, fluoroscopy, even MR-guided therapies are present. So that's something that's important. And then also the rehabilitation and looking at the entire system, nutrition, sleep, those foundational pieces. But for the things that we can mostly augment as practitioners, these are the 3 things that I think we should focus on. Future considerations, multiple treatments. Sometimes it's not a one and done, and that's okay. And have that conversation early on with patients. Say, hey, we can heal you, but it may take me 1, 2, or 3 treatments. And differentiating or stratifying patients that are on a curative course versus a maintenance, right? So that's something that I think is really important. That when somebody comes in and they have a calcific tendinitis, they have a rotator cuff or a tendon pathology or plantar fasciitis, I talk to them. I said, look, we want to cure this. We can fix this. It may take me a couple of rounds. You have to be patient with us, but we can get this better. When somebody comes in with in the regenerative medicine realms, a KL3 or severe arthritis, then we got to switch that conversation to a maintenance. I can give you a high quality of life and get you functional, but if you have enough birthdays and you're active enough, you're going to be back, right? And so that's the clear and concise message that we try to get across to our patients. Combination therapies are going to be exciting, right? So PRP, amniotic membrane, all the different types of stuff that's coming out. Stem cells, both autologous and potentially allogeneic in the future. Surgery plus therapies, so for like shoulder and surgical debridement, a decompression, if they have a type 3, acromion, or they're having some major mechanical issues, we might be able to heal the tendon, but if we don't take away that mechanical obstruction, they're just going to re-injure it. But then changing the biomechanics, so it's, it helps not injure the tendon further, and then using regenerative therapies. Strict dietary modifications. I'm actually on my day 3 of the Prolon, and I think it's been fabulous for our patients, reducing inflammation, helping with stem cell activation, using collagen supplements, laser therapies, class 4 laser with the future 1064 wavelength. I think is really exciting, something that can help tendon healing without having to poke a needle into somebody or to augment after you've done that if the patient needs further kind of activation, something that's exciting. And then biologically, metabolically enhancing clothing and wearables, something that we've been really interested in. So those are kind of the future considerations that are exciting in this field. So I wanted to keep it kind of short and sweet so we had some time for questions. And this is my email. If anybody's interested, please shoot me an email. I had the beautiful background pictures of Oregon. Our practice is growing. If there's anybody interested in joining us out here and building the practice, shoot me a line as well. But I'll hand it back to Dr. Morrey. I didn't have my tab up for questions, but we can take questions.
Well, thanks Thanks very much. That was an excellent presentation, a vast experience, very clearly delivered, and we really appreciate your taking the time to share that with us. Can you do this as an office procedure? The person indicated that they were interested in this, but there was a concern about reimbursement, and maybe I'll take a crack at that. Yes, this procedure can actually very readily be done as an office procedure. But you're quite right. The uniqueness of the reimbursement system in the United States requires to get reimbursed for the cost of the probe, it be done in a facility. And for that reason, most people do this in an ambulatory surgical facility, because the surgical facility can be appropriately reimbursed for the cost of the probe. The scientific component or the provider component is reimbursed independently, and that is quite adequate. So we would recommend that you have to explore your own reimbursement options that are available to you. But as of right now, it appears as though most find that it's most helpful in an ambulatory surgical center.
Our next question is, do you use laser with all your regenerative procedures? And if so, how do you use it?
I currently do not. Where we find that, so I don't use it for all. Where we find that it can be helpful is with patients with tendinopathies that are, for whatever reason, not going to be able to get an injection therapy and have the downtime. So if we need to get somebody, in-season athlete, or somebody that's going on a trip, or for whatever reason, initially we don't want to have the trauma of doing, because there is some healing time for all of these things. Instead of doing maybe a cortisone injection, to see a few rounds of the laser and see if it can help. The other time that we're using this is augmentation on the back end. So if we're doing a regenerative medicine therapy and patients are doing relatively well, or if they hit a plateau or not progressing at the pace that we would like, then augmenting them a couple times a week with the laser therapy and seeing if we can get them to get a boost in their therapy without having to augment again with a second or third regenerative medicine therapy. So that's probably the biggest place where we see, not only currently but in the future, a place for the Class 4 laser.
The next question that I see is, what is the cost of the Tenex? And the Tenex that removes calcific deposits, the recently released, it's called TXBone or calcific deposit. The list price is $12.95. The cost for the TX1 and TX2 is less. It's in the vicinity of $800. The question goes on to, what is the CPT code used for calcific tendinitis, and is it unlisted? No, there is a CPT code that is specific for removal of calcific tendinitis. I don't have the exact code, but there is an existing code that you can use legitimately. And if you send that question to Tenex, we'll give you the exact code. Insurance companies in Colorado have responded poorly for the present or the recent AMA statement about no longer reimbursing. Any recommendations? This is a difficult problem. The AMA, for reasons that are not clear, have recommended that even though when we do certainly tennis elbow and plantar fasciitis, it's a percutaneous partial fasciotomy, and there's an existing code for that. You should be able to use that. Also with tennis elbow, the use of a percutaneous tenotomy should be accepted, although the AMA does question that. The important thing that I would say in this regard is that the AMA's recommendation is not legally binding, and if the institution goes ahead and codes it as percutaneous tenotomy, and if you can justify it by saying the instrument was inserted percutaneously and we did a partial tenotomy of the diseased tendon In other words, if you can justify why you have elected not to follow the MA's advice, that is illegal. And the important thing is that you document the rationale of why you are not following their advice. The company is actively working on this, and so we hope that we can get a resolution. But the AMA has their views, and of course the company has its views. But the most important thing I'll tell you is you must share with the coders that this is advisory. The AMA's activity is not legally, or recommendations are not legally binding. And hopefully that will help you through some of your issues. If you use Tenex more than one tendon, supraspinatus, infraspinatus, do you bill for multiple tendons? There's a specific code that discusses single tendon and multiple tendon, and use the code for multiple tendon if you have, in fact, treated more than one. Any issues, reimbursement in this scenario? I'm not specifically aware of those. My understanding is that with the newer applications to the bone and the soft and the calcific tissue, there are existing codes that appear to be legitimately used by Tenex to discuss removing bone and debriding tissue. And so we think that the bony applications do have a greater opportunity to be accepted and coded, or I should say coded and accepted, possibly than the soft tissue applications. There's a really great study on PRP and Tenex that shows equivalent results. What are our thoughts? I am familiar with this study, and I think that the way that the study was constructed and the way the parameters for outcome was constructed, those parameters are roughly the same for both. It is true that PRP appears to be variably effective in different anatomic parts. Probably the best application is the elbow. There's some question about how effective it is at other areas. Our data in the publications that we have suggest that the Tenex is fairly consistent in terms of its efficacy, between 85 and 90 to maybe 95% in some instances. The other thing that I think does make a difference is to the extent that the Tenex continues to be covered by insurance. If they are equivalent in their outcome, it is clearly less painful. There's no question about that. PRP hurts, and PRP is out of pocket. So if we add those variables, we feel as though that study shows that if you add those additional features, that it's probably more desirable to be using the Tenex procedure than the PRP.
Dr. Morrey, on that point,
yes.
Clinically, I wanted to, from some experience, I have been very surprised at the lack of pain that many, many patients experience with Tenex. When you look at what we're doing and how robust the needle is, and that there is that ultrasonic energy that's being deposited, and you're doing the lavage and aspiration, that you'd feel that a lot of, at least my expectation was that more of the patients would have severe pain. And I am surprised, especially when patients come in, if they have a relatively active phase of tendinopathy or calcific tendinitis, that there are times when they're coming back in, or giving me that insight that literally the next day we have massive amounts of pain relief. And so it is really interesting to see, and that is, and many times I'm shocked that we've been so, what I feel like, compared, as an injectionist and an interventionalist, doing something that's relatively aggressive with the tissues, how well patients do respond.
That's a good point. And one thing that I noticed specific with calcific tendinopathy, the alternatives to treatment are numerous, and it would seem as though some were really attractive. For example, as an orthopedic surgeon, a lot of my colleagues would do an arthroscopic removal and or limited open. And what I am told by those that have used the Tenex for calcific deposit removal versus any of the other options is that in spite of what seems to be a relatively limited approach with those other procedures, there is still significant morbidity. And Steve Yoon, who is at Curlin Job Clinic, told me that probably his best patient group is calcific tendinopathy because they do so much better than any of the alternatives. They simply don't hurt as much, and the shoulder particularly is extremely challenging to avoid a chronic, long-term, painful rehab process. But the advantage of this procedure appears, among other things, to be that it's just relatively pain-free, and the rehabilitation is much more favorable. When is it a failure, and kind of what do you do about it? In our experience, and I've done just less than 500, over 400, we consider if we look at the normal healing response, about 10 to 20% of the patients will seem to have almost no pain immediately within the first 2 weeks. When the local wears off, it's just amazing. But you can't anticipate that, or you can't project that, and you never tell a patient that. What we tell the patient is expect 2 to 3 months before they see a significant benefit to where the part doesn't hurt very much and they're doing very, very well. And I've had a number of patients, I'll say 10%, that improve between 3 and 6 months. So it's important to understand that we consider the healing opportunity to be up to 6 months. If a patient comes back at 6 months and they're still having problems, then we consider it a failure. And of the ones that I have done, I can recall 7 or 8 redos. And when they come back, we can offer them, depending upon the anatomic part, an open procedure or a redo 10X or PRP, or they can go to somebody else and see if they have something better. And in every instance of at least the patients of mine that didn't heal at the initial treatment, all of them have asked for another 10X procedure. And I'm aware of one person that has actually come back for a second redo. And this, of course, would be the father-in-law of an orthopedic surgeon whom I trained at Mayo, so that has to be the case. But he had pain in a slightly different area. And as I looked at the redos I did, about half of them actually had pain in an area that was several centimeters away. And so I think the so-called recurrences may have actually been progression of the degenerative process. And so we just treated a different part of the tendon, and those patients have done well. How soon after 10X do you begin regenerative injections? I'll turn that over to Rahul. It's how soon after 10X would you do a regenerative, or would you do an injection of a biologic or a regenerative?
That's a good question. So I'm kind of two. One of the, one just from necessity is separating them by a few days. And when that happens is we have there is a surgery center that I work at that currently covers this procedure. And so if we do a 10X procedure, whatever the body part may be, I'll usually talk to the patient, depending on, again, the stratification of how bad their particular pathway is if I think that a biologic would be indicated. If it is indicated and they're doing the procedure at a surgery center, then we'll separate it by at least a couple of days. And so we'll do the procedure, and then we'll bring them back in the office setting and do the injection. One of the discussion points there, plus or minus, is simply that you are using a lavage technique, and that by placing the biologic in a lavaged tissue bed, that you may be diluting some of that effect. So by bringing them back in a couple of days and then using kind of a fenestrative technique where you treated, that's usually our technique. There are times when we do everything. We actually have the entire procedure done in the clinical office setting. It's kind of a bundled therapy where we do everything together. That Achilles tendon case was that type of procedure. The patient flew in from out of town, and we did the procedure. So everything was done the same day. We harvested the cells, processed them, did the Tenex, and then delivered the cells right after the procedure, and they still did tremendously well. So I don't have any, particular data demonstrating superiority of one method or the other. And then the other part, kind of going back to the last question, something that I will at least have that discussion with patients is that, if somebody has a relatively mild disease process, or I feel like the Tenex in and of itself may help the patient heal and we don't need a biologic, then we'll reserve that, but I'll have that discussion early on. So I'll talk to them about, hey, we're going to do this Tenex, we're going to give it 8, 12, 16 weeks to heal. If we feel like, we made some serious progress and things are great, but they're not where we need to be, we haven't reached your therapeutic ceiling, then we have, either a repeat Tenex, or if the tendon's looking pretty decent, then consideration of a biologic at that time to boost the healing. And going back to what Dr. Morrey was talking about, it's one thing that you have to have those discussions early and often is to be patient with the reparative process. We've seen so many patients that we actually thought were failures, and we gave a few more weeks and they were in process of maybe looking at an alternative, and it turned around. So, having that window of 6 months is something that is realistic, that you may see patients turn around. And we're also seeing the success rate, hover around that 90% mark. So pretty tremendous. Proper selection and, methodology of what you're doing, you're going to have very high success rates with this.
If I could add just a little bit to that, and then I'll take the next question. In the Curl and Joe Clinic, and I think I can speak for them because we're very close to the organizers and the people that use it a lot. With their professional athletes, just as Rahul said, they double down. They do 10X and then they do immediate biologics. However, if this is covered by insurance, insurance will deny coverage if you do a biologic at exactly the same time. Therefore, I recommend, if you feel that that is important, my strategy is to treat them with 10X only. And if about 3 or 4 weeks, they just don't seem to be recovering yet, or they're not making much progress, or they're concerned about it, you can then chase it, so to speak, with the chaser of a biologic. And at that time interval, your procedure is covered, and the biologic doesn't negate the insurance coverage. Plus, it might make sense. The thing that I think is very important conceptually is, Rahul mentioned it very clearly, we feel like when you use 10X, you are defining the stage of the disease. The stage of the disease is one in which the degenerative tendon is gone, and you have stimulated the initiation of a healing response. And then you have to think, what are the biologics doing? Are they stimulating the response? You've done that. So do they enhance the response that's already been stimulated? This would be an interesting area to study, but I'm okay to consider primarily the latter, that it potentiates something that's already been started. And since I think the 10X removes the tendon and starts the process, it makes some sense to me to follow up at a discrete period of time that is after the window that will deny insurance coverage with your biologic, or wait until they don't seem to be making progress even further down the road and then use it. There's a question about whether or not there's experience with plantar fibromas. That's a very interesting question because it turns out we do have experience, and it's actually been published in the peer-reviewed literature. One of our colleagues, Mahir Patel, who's an orthopedic surgeon, foot surgeon, trained at Hospital of Special Surgery, and he's at Ortho, Indiana, wrote up, I think, 12 cases of plantar fibroma that he followed for a year, and he had no instance of recurrence in that sample of 12. So his limited experience with limited follow-up at a year is actually very favorable. He didn't have any problems and didn't have any complications that was reported in that study.
For common extensor tendinosis, at what point would you not use Tenex? For example, in the size of the tear, high grade above 50% tear, or so forth.
I'm going to let Rahul take that because I thought his Achilles, one of the things I was taking with that Achilles example is that tendon was almost completely replaced. So that was a tendon that was an impending rupture in my mind. So Rahul, what do you have rules of thumb for when you think it's just too big to treat with Tenex?
Well, if it's too big to treat with Tenex, or when we wouldn't.
Well, I guess maybe either. When you look at it and you say, holy smokes, this involves 70% of the tendon. You've only got 30% left. I'm not sure that's enough. I think it's going to rupture. Maybe you need it open. Is there a percentage displacement or replacement of a normal tendon by a degenerative tendon that you would say this is just too much for Tenex to be expected to do? Again, the Achilles tendon that you showed, I thought was dramatic in that was virtually the whole tendon was diseased, and yet you treated it successfully.
Yeah, I think if there's, the kind of a hypertrophic process, and, the big thing for me is having a scaffold for regeneration, right? For having the cells to be able to have the ability to get to the other side. And so with a hypertrophic process, I think there's less limitation, and you just try to clean out as much of the diseased tissue as possible, and then depending on how much is left and what you're using as your biologic, then having maybe some immobilization as a component of that. I think that where I see it more concerning is if there's a very atrophic tendon, right? And so we had one example of that, and we've seen where tendons are just hanging on by a thread, and even biologics can fail at that time. But if there is not a lot of scaffolding, then I would definitely hesitate with Tenex and maybe try the straight biologic route first. And then when there's absolutely no scaffolding and there's no tissue, then I think you need surgery, right? So if somebody has an acute or subacute tear with anything over 8-9 millimeters and the rotator cable is not holding the tissue together, then I think that for the shoulder, that needs to go see the surgeon. Or if there's a complete rupture. But as far as when somebody has hypertrophic disease, that hasn't stopped me from moving forward.
Okay. Well, there's a variation on the theme, Rahul, and that is in calcific shoulder pathology. Is there a size of a calcific deposit that you would worry about? Not so much that you can't get it out, but that it's replaced so much of the normal tendon that you can't get it out. Let me just start real quickly by saying, as a surgeon, if you're going to take it out surgically or any other way, I will guarantee you remove a lot more normal tissue than you do if you take it out by Tenex. So if you're trying to preserve as much as you can, then the Tenex procedure is by far the treatment of choice. But going to the question, Rahul, have you seen a calcific deposit that virtually replaced all the tendon or the tendon attachment, and you were concerned if you took it out, the tendon would frankly rupture?
No, that I have not. And I've had some huge, actually, I'm just more excited when I see a calcium deposit that big, because I know it's going to be a successful therapy. So even though it appears that it's replacing the entire tendon, there's still tendon tissue that's present. And by removing that large deposit, we're seeing that a much more native. And I almost image everybody that I treat. It's just I want to see what's happening, and so we do follow-up imaging with either ultrasound or oftentimes with MRI. And we have not had that issue where we've removed the deposit and have ended up with a full thickness or large partial thickness tear.
Thank you. This is a very interesting question because of the timing. They're asking for additional applications extending the indication, and ask if we had any experience with perineal tendinitis. The reason it's interesting is about an hour before the webinar started, Dr. Walt Sussman from Tufts sent me an email saying that his paper on peroneal tendinopathy treated by Tenex was accepted in the Journal of Foot and Ankle Surgery. So the answer is yes, there is experience. I've read the manuscript, and it's about 90% successful, and it'll be out in the peer review literature whenever that can process through that particular journal. There's a couple of redundant questions about the biological supplements and when used together, can it be used independently? I hope we've answered that. By the way, if there's anything that we touched on but didn't get to what you were really asking, please don't hesitate to contact me or Rahul, if I may speak for you. I know you're very busy, but Rahul has so much experience, I'm sure he'd be willing to share some of the experience. So you can send an email to me, and if I can answer it, I can forward it to Rahul, if that's okay.
Yep, that's fine.
That's it. Good. A question regarding using lasers with your regenerative procedures, and how often do you do it? So, question of how do you do the laser? How often do you use laser with the combination with your regenerative supplements?
Yeah, I think we kind of answered that question before, but
you don't really, do you?
Well, we do. We're using it more and more often. And again, if it's an in-season athlete, then we're going to be more aggressive with it. If it's somebody that has the ability to take some downtime, and again, it's stratification of the disease, that if we feel like the laser is not going to be able to do the healing fully, or we've tried and failed, then I always start conservatively. So the less that we can traumatize the tissue, traumatize the patient, start there. And then if we need to move up the line, then we do that. So the other time that we utilize it, as I spoke of before, is if we have done a therapy and they're not complete, either they've done well and now they're plateaued and we need a little bit more improvement. That's when we would utilize it. Or if we feel like, hey, this is potentially an impending failure where there's a lot of postoperative pain, that's another time to utilize this therapy.
Okay. And then there's a couple of other questions surrounding the biologics and how do you select which one and which you think is best. And that might be a little bit more of an involved discussion. I know there's a lot of preference. You try to follow the science, but we're right at the 1 hour and trying to be respectful of everybody's time. I think that covers most of the central questions. I don't think there's a question that hasn't been kind of repeated or already addressed in some way. So I think with that, I'll call this session to a close. Can't thank enough Dr. Desai for his excellent presentation and sharing his vast experience and very thoughtful and intellectual approach to the problem, as well as the attendees. I must tell you, this may be the largest webinar that we've had. We were oversubscribed, and we only have 101 slots. And so there was over 20 individuals that weren't able to join, which is disappointing on the one hand, but makes us very pleased on the other. We plan to have another webinar for your information at the end of the month. Anticipation right now is Dr. Freed will be talking about diabetic foot ulcers, which is probably a different crowd. So with that, I'll bid you all a good night, and thanks again once again for your time and for your questions. And Rahul, thank you very much. Excellent job.
Yeah, thank you, Lily. Thank you, Dr. Morrey.